Welcome to the Radiographics Podcast. I'm Wende Gibbs. This week, Dr. Frederick will give us a summary of a valuable multisystem article detailing the myriad manifestations of neurofibromatosis. And I'll discuss a paper on coronary artery calcium scoring. This is a topic I hadn't thought much about since, internship and residency, but it's very important, and this is a useful update. Coronary artery calcium scoring. Current status and future directions. In this issue of Radiographics, we have an excellent overview of coronary artery calcium scoring. In addition to describing the different types of CAC scores and the current utility of CAC scoring, the authors discuss in detail the technique of scan acquisition, the associated pitfalls and potential solutions, and the importance of extracardiac and incidental findings. They also describe a structured algorithmic approach for interpreting CAC scoring that will undoubtedly serve as a great tool for all imagers involved in reading such studies. CAC scoring with use of non-contrast ECG-gated CT has emerged as a fast, inexpensive, reproducible examination that involves a low ionizing radiation dose and yields powerful prognostic data. The importance of CAC in predicting the risk of coronary heart disease is undeniable, with a 10-fold higher risk in patients who have a CAC score higher than 300 compared with the risk for those without any coronary artery calcium. This risk is incremental to traditional risk factors. Moreover, the CAC score, as compared with traditional risk factors, is a stronger predictor of coronary heart disease events. High CAC levels are associated with not only heart disease, but also increased all-cause mortality, non-cardiovascular mortality, myocardial infarction, coronary revascularization, atrial fibrillation, and cardiovascular disease. It's been shown that identification of coronary artery calcium leads to an increased rate of initiation or continuation of lipid-lowering therapies, blood pressure-lowering therapies, aspirin, and positive lifestyle changes, including dietary modifications and increased exercise. In this review, the authors also describe the utility of coronary artery calcium scoring in clinical guidelines. It's worth re-emphasizing that the calcium score is no longer used as a screening tool. Rather, it's now considered a decision-aiding tool. This is evident in the 2018 American College of Cardiology American Heart Association Multi-Society Guideline on the Management of Blood Cholesterol. In this guideline, a Class 2A recommendation is given for the use of coronary artery calcium to aid decision-making with regard to the use of statin therapy when there's uncertainty in patients with intermediate, meaning 7.5% to 20%, 10-year atherosclerotic cardiovascular disease risk, and in select patients with borderline risk, which is 5 to 7.5%. Coronary artery calcium scoring has changed risk stratification as it enables identification of patients with low risk. An important use of the calcium score is its role as a negative risk factor that can help exclude risk in patients when coronary artery calcium is absent. A CAC score of 0 outperformed numerous other negative risk markers in downward risk reclassification. CAC can be considered a marker of biologic aging, and elderly patients with absent or minimal CAC, meaning a score of less than 10, can be considered to have healthy vascular aging. In one study, in elderly patients with absent coronary artery calcification, the observed risk of heart disease was 80% lower than that predicted by using traditional risk factors. Approximately half of individuals who meet the guideline criteria for statin treatment have a calcium score of 0, and can be considered to have low risk and a CAC level below the threshold for statin therapy. Therefore, current guidelines support withholding statin therapy in individuals with a CAC score of 0 who do not have diabetes or a strong family history of premature heart disease and who do not currently smoke. At the other end of the spectrum, an extremely high CAC score, greater than 1,000, has been shown to be associated with increased risks of heart disease, cardiovascular disease, cancer, and all-cause mortality, with an approximately 2-fold increased risk of cardiovascular disease mortality compared with this risk for patients who have the slightly lower scores, 400 to 999. There's emerging data on CAC detection in young individuals, and the importance of this detection in identifying those with high CVD risk. Approximately 10% of those 32 to 46 years old and 30% of patients 42 to 56 years old have been found to have coronary artery calcium. In young patients, which they're considered to be less than 30, With 3 or more traditional risk factors, CAC prevalence is 35%. Compared with individuals with no coronary artery calcium, young individuals with high levels have been shown to have higher all-cause mortality rates. New insights from the multi-ethnic study of atherosclerosis reveal that age, sex, baseline cardiovascular disease risk, race or ethnicity, and diabetes status influence the duration of time for progression from a CAC score of 0 to a score greater than 0. These data suggest that repeat scanning at 3 to 7 years based on the demographic profile and presence of risk factors may be appropriate. We should be cautious when interpreting CAC scores in patients undergoing statin therapy. Despite suggestions that statin therapy may promote CAC, there's evidence that CAC scoring still may be relevant, as calcium volume, not calcium density, has been associated with heart disease and vascular disease risk in patients on statins. Although existing CAC scoring has yielded invaluable prognostic information, it's not perfect. Several strategies for improving existing CAC scores are described in this article. Techniques that may improve the existing calcium score include inverse weighting of attenuation, regional distribution of calcification, and incorporation of extracoronary calcification. In addition, the amount of epicardial fat and the presence of hepatic steatosis can be assessed, and without acquiring additional images. The potentially increased complexity of analysis and examination interpretation may limit the use of these techniques and will be an important consideration before incorporation into clinical practice. Patients who undergo non-contrast thoracic CT for lung cancer screening share risk factors with those who have heart disease and will benefit from CAC assessment in addition to a search for lung nodules. The importance of CAC assessment on all non-contrast, non-ECG gated scans is evident by the Class 1 recommendation from the Society for Cardiovascular CT for qualitative assessment of the amount of coronary calcium on such scans. In the future, accurate CAC scoring may become possible with use of advanced artificial intelligence techniques. In addition, there's enormous potential for the opportunistic detection of coronary atherosclerosis with the use of non-contrast, non-ECG gated CT scans and virtual non-contrast CT scans acquired for other purposes. That's something we talked about on the podcast last year, opportunistic screening. Finally, coronary calcium scoring is extremely valuable for early detection and prevention of adverse cardiovascular events, as a decision-aiding tool for initiation of statin therapy, and as a negative risk factor for excluding cardiovascular disease risk in patients. Cardiac imagers should be cognizant of emerging indications for coronary artery calcium scoring in young individuals, in individuals undergoing statin therapy, at repeat testing, and at non-dedicated CT scanning. Okay, now let's switch gears and hear about neurofibromatosis.
Neurofibromatosis from head to toe. What the radiologist needs to know. Props to Dr. Mindy Wang and crew for coming up with a crafty little rhyme in their title. NF1 and NF2 are autosomal dominant inherited neurocutaneous disorders that share a common name. However, they are distinct disorders with a wide range of clinical and imaging manifestations. NF1 is much more common and has a prevalence of 1 in 4,000 to 5,000. Approximately 50% of NF1 mutations are sporadic. NF2 has a prevalence of just 1 in 60,000. Similarly, about 50% of individuals present with sporadic mutations. The key diagnostic criteria for NF1 includes multiple café-au-lait spots, axillary or inguinal freckling, more than 2 regular neurofibromas or 1 plexiform neurofibroma, optic pathway glioma, Lisch nodules or hyperosamortomas, and a distinctive osseous lesion such as sphenoid dysplasia, anterolateral bowing of the tibia, or pseudoarthrosis of a long bone. First, let's cover findings in NF1. Dermal and subcutaneous neurofibromas are benign peripheral nerve sheath tumors, occurring in approximately 60% of NF1 patients. While generally diagnosed on physical exam, they are often seen on imaging when looking for deeper lesions. On ultrasound, they manifest as well-defined oval hypoechoic masses contiguous with peripheral nerves, often demonstrating posterior acoustic enhancement. On color Doppler, internal flow is expected, although they are generally hypovascular. On CT, they manifest as soft tissue masses with low attenuation. On MRI, neurofibromas may demonstrate the target sign, which is hyperintense peripheral rim and hypointense central fibrous component on T2 images, and they show central enhancement. Malignant transformation in cutaneous neurofibromas is exceedingly rare. Plexiform neurofibromas are complex deep or superficial masses that arise from peripheral nerve sheaths, occurring in about half of patients with NF1. They appear as thickened, firm masses or nodules that may deeply infiltrate structures, causing disfigurement and dysfunction. On MRI, they manifest as multinodular confluent masses with mass effect on surrounding structures and multiple target signs on T2 images. Surgical removal is often difficult. Owing to the moderately high risk of developing breast cancer, patients with NF1 should undergo screening mammography starting at the age of 30 years. However, the presence of cutaneous neurofibromas may pose a diagnostic challenge for mammographic interpretation. Sphenoid wing dysplasia is a hallmark skull abnormality in NF1 patients attributed to mesodermal dysplasia, occurring in more than 10% of cases. It manifests as greater and lesser sphenoid wing hypoplasia, which is indicated by the bare orbit sign, which is the absence of the innominate line on X-ray and CT. Associated widening of the middle cranial fossa, widening of the orbital fissures, and flattening of the posterior orbit may result in pulsatile exophthalmos. Over half of these patients have an associated plexiform tumor that disrupts bone modeling. Let's discuss CNS manifestations of NF1. Focal areas of signal intensity, or FOSSEs, are common MRI findings, occurring in approximately 70% of cases. Temporal change in number and size is noted, appearing by the age of 3 years, followed by a size decrease after the age of 20. Histologically, they demonstrate abnormally increased white matter volume related to spongiform myelopathy and myelin vacuolization. On MRI, FOSSEs demonstrate focal or diffuse T2 flare hyperintensity. They show no enhancement or mass effect. Optic pathway gliomas are the most common CNS tumors in NF1, occurring in approximately 20% of cases. These gliomas can involve any portion of the optic pathway. They are more indolent than in patients without NF1. They tend to manifest in young children with a median age of 4 years. Histologically, they're often distinguished as pilocytic astrocytomas. On MRI, they demonstrate enlargement of the optic nerve sheath complex with increased T2 signal and variable enhancement. Although most of these tumors may regress without treatment, chemotherapy is used when there is progressive vision loss. Less commonly, NF1 patients can have non-optic pathway gliomas, usually pilocytic astrocytomas. Dural and meningocele occur along the same spectrum, occurring in 75% of NF1 patients. Dural represents focal dilatation of the dural sac, which may be related to underlying bony weakness. Meningocele occurs along the course of nerve roots at the anterior or anterolateral aspect of the vertebral column and in the thoracic spine as a result of pressure differences between the thorax and subarachnoid space. Both follow CSF signal on MRI. On myelography, intrathecally injected contrast material fills these spaces. They are often associated with vertebral defects and spine scoliosis. In addition to cutaneous involvement, neurofibromas and plexiform neurofibromas may involve the spinal cord and spinal nerve roots. Paraspinal neurofibromas can manifest as solitary or multiple dumbbell-shaped masses with paraspinal or intradural extramedullary components associated with enlarged neuroforamina, scoliosis, vertebral dysplasia, and possible spinal cord compression. Malignant peripheral nerve sheath tumors are highly malignant soft tissue sarcomas that can arise from any neurofibroma. They can infiltrate surrounding soft tissue, cause peritumor edema, and are often located in the extremities and trunk. Patients may present with persistent pain, rapid growth, or new hard texture, and new or unexplained neurologic deficit associated with a neurofibroma. Malignant peripheral nerve sheath tumors are key contributors to mortality in patients with NF1. On MRI, malignant degeneration is suggested by heterogeneous signal intensity on T1 weighted images. 4 imaging features can help differentiate malignant peripheral nerve sheath tumor from benign neurofibroma on MRI. Large dimension of the mass, peripheral enhancement pattern, perilesion edema-like zone, and intratumor cystic changes. Additional features that favor malignant peripheral nerve sheath tumor include ill-defined margins, intratumor lobulation, and adjacent bone destruction. On FDG PET, malignant peripheral nerve sheath tumors generally demonstrate an SUV max greater than 3.5, while benign lesions demonstrate an SUV max less than 2.5, although there is some overlap. Surgical resection is the primary treatment. Unfortunately, though, recurrence is common even with negative surgical margins. NF1 also has pulmonary manifestations, including interstitial lung disease, cyst or bulla formation, and pulmonary hypertension, occurring in 10 to 20%. Interstitial lung disease usually manifests as nonspecific interstitial pneumonia, or NSIP, seen as linear and ground glass opacities that are bilateral, symmetric, and basal predominant. Let's move on to abdominopelvic manifestations of NF1. As expected, neurofibromas are the most common manifestation and are often seen in the retroperitoneum and pelvis along the distribution of the lumbosacral plexus. When a large conglomerate of neurofibromas is seen, it is considered a plexiform neurofibroma, which appears as large infiltrating masses. When the bow wall nerve plexus is involved, neurofibromas can manifest as circumferential mass-like wall thickening with or without obstruction. Vascular narrowing may occur, which can cause bowel ischemia. Gastrointestinal stromal tumors can occur in up to 25% of individuals with NF1, although half are asymptomatic. On CT and MRI, they are submucosal bowel wall masses with either an endophytic, exophytic, or mixed growth pattern. They typically enhance, although enhancement can be heterogeneous in larger tumors owing to necrosis. Pheochromocytomas are catecholamine-secreting tumors that arise from chromaffin cells of the sympathetic nervous system and occur in 4% of individuals with NF1. On CT, pheochromocytomas are typically well-circumscribed masses in the adrenal gland. They can be homogeneously enhancing, although when large, they often exhibit heterogeneity due to internal hemorrhage, necrosis, or cystic changes. On MRI, they classically exhibit T2 hyperintensity similar to that of CSF, the light bulb sign. Iodine-123 MIBG scintigraphy can help detect functional lesions. Several skeletal abnormalities are commonly associated with NF1, including scoliosis, posterior vertebral scalloping, and various bone dysplasias. Vertebral body scalloping occurs as a result of dural neurofibromas, or thoracic meningoceles, and is possibly related to dural weakness. Additionally, involvement of the extremities can be seen, especially in the tibia and fibula, with anterolateral tibial bowing, fracture, and pseudoarthrosis due to abnormal bone remodeling. NF1-associated vasculopathy can affect any arterial vessel, resulting in hypertension from renal artery stenosis, cerebrovascular events, or peripheral vascular insufficiency. Renal artery stenosis is the most common vascular abnormality in NF1. The stenosis can be focal or multifocal and is often unilateral. On CT and MRI, smooth narrowing at the ostia can be seen along with narrowing of other vessels, including the mesenteric arteries and abdominal aorta. Aside from renal artery stenosis, NF1-associated vasculopathy can manifest as cerebrovascular disease with stenosis or occlusion of the internal carotid, middle cerebral, or anterior cerebral artery. Moyamoya disease, aneurysm, and arteriovenous malformation can also occur. In Moyamoya disease, the terminal internal carotid artery or proximal portions of the anterior or middle cerebral artery are often obstructed and associated with collateral vessels. Let's move on to the less common NF2. Unlike NF1, NF2 often manifests clinically in early adulthood with symptoms related to vestibular schwannomas. Early age of symptom onset and the presence of intracranial meningiomas at diagnosis are associated with increased mortality. Key NF2 manifestations include schwannomas, meningiomas, and ependymomas. Cutaneous findings may be present but are much less common in NF2. Let's touch on schwannomas. Approximately 95% of adults with NF2 develop vestibular schwannomas at a mean age of 26 years. The presence of bilateral vestibular schwannomas is highly suggestive of NF2. Schwannomas may also involve other cranial nerves, spinal nerve roots, and peripheral nerves. On MRI, schwannomas are T2 hyperintense, typically in a gyroform pattern that reflects their leptomeningeal pattern of spread. They demonstrate heterogeneous enhancement due to necrosis, hemorrhage, or cystic changes. Large vestibular schwannomas may manifest with concerning findings, such as brainstem or cerebellar compression, tonsillar herniation, hydrocephalus, or peritumor edema. In the spine, they are intradural extramedullary masses, commonly found at the level of C1. Intracranial and spinal meningiomas are the second most common tumors in NF2. On CT, meningiomas are dural-based hyperattenuating masses, and on MRI, they have homogeneous enhancement with a dural tail. They are associated with hyperostosis of the adjacent calvaria. In the spine, they are also intradural extramedullary masses. Ependymomas are low-grade intramedullary tumors occurring in half of individuals with NF2. They often occur in the cervical spinal cord or at the cervical-medullary junction, although they can rarely occur intracranially. Patients are often asymptomatic owing to the indolent nature of these tumors. On MRI, the intramedullary masses are T2 hyperintense with homogeneous enhancement. When there are multiple lesions, they resemble a string of pearls on contrast-enhanced images. A hemosiderin cap may be seen at the superior and inferior poles of this tumor. Alright, moving on to life expectancy and surveillance. Although many patients with NF1 survive into adulthood, average life expectancy is decreased to 54 years, largely due to malignancy. The average survival in NF2 is slightly higher at 62 years. Surveillance of these patients is very important. Recently, whole-body MRI has emerged as a potential option for NF1 surveillance due to its lack of radiation and new, more efficient imaging protocols. Although whole-body MRI can allow early detection of many NF1 manifestations, it is particularly useful in detecting and quantifying peripheral nerve sheath tumors. This is important as an increased number of peripheral nerve sheath tumors is associated with an increased risk of malignant transformation. Patients with NF2 should undergo regular surveillance with annual MRIs of the brain and MRIs of the spine every 3 to 5 years. Alright, let's recap. NF2 is much more simple. Its manifestations are easier to remember. It's all about schwannomas, meningiomas, and ependymomas. Now back to NF1. Remember that phases demonstrate focal or diffuse T2 hyperintensity in the basal ganglia, cerebellum, or brainstem. They generally exhibit isointensity or mild hyperintensity on T1 images, no enhancement, and no mass effect. Gliomas are distinguished from phases by the presence of mass effect, their T2 characteristics, contrast enhancement, and evolution over time. On MRI, malignant degeneration of a peripheral nerve sheath tumor is suggested by heterogeneous T1 signal. And remember the 4 imaging features that can help differentiate malignant peripheral nerve sheath tumor from benign neurofibroma on MRI. Large dimension of the mass, peripheral enhancement pattern, perilesion edema-like zone, and intratumor cystic changes.
Alright, that's it for this week's podcast. Take a look at these great articles and more on the website and find summaries and cases on Twitter. We'll be back in a few weeks with more summaries.